Good morning, everyone, and welcome to the Stanford Cancer Institute Frontiers in Oncology webinar. I'm Surbhi Sedana. I'm an assistant professor in the Division of BMT and Cellular Therapy at Stanford. Today, I have the pleasure of hosting Dr. Tarec El-Galaly, who is a clinical professor of hematology at Aalborg University in Denmark. His expertise is in lymphoma and epidemiology. He chairs the National Committee in Denmark on Ethics in Clinical Trials, and his work is focused on epidemiology and real-world data in clinical practice. He has authored over 100 papers, and today he'll talk to us about the pitfalls and benefits of using real-world data in clinical practice. Dr. El-Galaly, welcome. I look forward to your talk.
Thanks a lot. Thanks, Sophie. I'll just share my slides. Okay, thanks a lot for hosting me for this webinar, and I've been really looking forward to it. And today I'll be talking a little about the potential and pitfalls for use of real-world data to inform clinical practice. So I will be discussing first what is actually real-world data and what does it cover, and also then as a couple of examples on potential applications, for example, for development of new therapies, also for improving current clinical practice, for evaluating treatment effectiveness in real-world setting, and also understanding late toxicities. Finally, I hope we have time for some discussion. So if I don't have time to go through all of these points, then I will prioritize the discussion part. So many have started using real-world data for something quite different than the classical epidemiology. For example, you all are aware of the classical epidemiology, where you look at a disease and exposure and try to delineate what causes disease, and maybe you have confounders you can adjust for. For real-world evidence studies, at least the type I've been working quite a lot with, is there is a focus on the disease first, and then look at how the disease is treated, how you can develop prognostic models from the data you collect on the disease. For example, diagnostic workup or outcomes over time, and healthcare utilization. So this is more centered on the disease, and then look at how does the patient do, and what kind of treatments do the patient go through, and what is the effect. Real-world data is a lot of things. So the more conventional real-world data is the medical charts, for example, archived biological material from patients treated in the real-world setting. And databases, we have a lot of databases in Denmark, administrative databases. But there are also a lot of newer forms of real-world data that maybe has not been used so much to this date, but I'm sure it will be much more common to include this. This is, of course, the patient-reported outcomes. Patients also collect a lot of data on their devices from health apps and similar things. And also the social networks, for example, how can you use Facebook and all these things to collect data? There's really no standard definition of real-world data, so this is a lot of things. If you ask experts, there were 38 different definitions, and these definitions were grouped into 4 different categories. So one group was that everything that was not a randomized clinical trial was considered real-world data. Another way of defining it was that data that was collected in a non-interventional, non-controlled setting was real-world data. And then finally, probably a more common definition, that data collected outside an experimental setting, meaning no de novo data collection, that is real-world data. And these definitions actually matter quite a lot when you discuss the applicability of real-world data and the potential and pitfalls. Because if you look at this like on a line from the more conservative definition to the most extreme definition, then considering that everything outside a randomized clinical trial is real-world data, that would include single-arm trials, non-interventional trials, and also the non-experimental data. This is really a lot of different sources for real-world data, and this also allows for a lot of different study designs with very high quality data. On the other hand, if you only consider data that is collected in a non-experimental setting as real-world data, then you have much more limited data, and then you have all the issues of missing data and bias. This is really the situation where you can talk about the secondary use of data that was collected for another purpose. One thing that is quite important is that the term prospective and retrospective is typically not a part of the definition. So even in the non-experimental setting, actually a lot of the data will be collected prospectively. For example, if you have administrative databases, these data are collected without knowing the outcome or without knowing the purpose of the study. These were collected for some other purpose. But of course, the analysis is retrospective. I think things have changed a lot for real-world data and real-world evidence in the recent 10 years. I think it's time to ask if this is a hype or really a hope that it can solve a lot of things. And can we really solve tomorrow's problems by using yesterday's data? And I think the truth is probably somewhere in between. I don't think that we can solve everything using real-world data or observational data. But I think that the evidence hierarchy that we all know, this classical evidence hierarchy, that this will have to change for a number of reasons. And most importantly, I think the more refined disease classification with very small patient subgroup really puts a limitation to how you can conduct randomized trials. And I also think that we have much more treatment options now and more treatments in development. And this means that there's simply a limited capacity to explore everything in large randomized trials. So I think the future will be that we need to look at the totality of the evidence much more than we do today. And this will, of course, include a lot of real-world evidence. And I think another sign that this is really changing is that some years ago, or many years ago, real-world data was like the Wild West. You had no structure of reporting it. You had maybe a lot of flexibility in analytics and not so much transparency, whereas now we see so much in recent years coming out from academia on how to report these trials, how to report data from real-world data so that it's reproducible. And we also see regulators, FDA and EMA stating positions on how they want things to be and how they want things to be transparent. So I think this is also a sign that this is recognized as being an increasingly important data source for clinical practice. I think it's important also to recognize that it's really critical that when you conduct these studies that we think about the reproducibility more than we have done previously, I would say, because there are so many decisions taken when you do a real-world data study, and this all affects the outcome of the study and the results, and thereby also what you take from it into clinical practice. So you have so many steps from the data extraction or the selection of the data source and how you want to clean this, to how you want to organize the data, to making an analytic data set where you define your exposures, you define the outcomes, you define the follow-up and covariates, and then again, how you analyze it. You can do this in a number of different ways. All these steps can have significant implications on what the results looks like. I'll just briefly talk about real-world data in drug development because I think this is an exciting area, and I think this is one of the more recent developments and more recent use. And as you know, there has been real-world data has been used in clinical development for a number of years, for a long time. The classical use is to identify gaps and unmet needs, and maybe benchmarking for development strategies, like is a new therapy promising? Does this therapy have response rate comparable to what's available now? And in these earlier ways of using real-world data, then I think clinical decisions will not really be based on the data. And if you have poor data, then you may do poor development, but you're not really risking implementing poor treatments. But I think now we're seeing increasing use of real-world data in later stages, for example, for benchmarking clinical efficacy in larger phase 2 trials, where we actually use this also for assessing the efficacy of the treatments. And there's even talk also of replacing control arms with hybrid designs or synthetic control arms. And I think when we move into this area, then I really think we need to be much more careful, because then we risk making clinical decisions or decisions based on these data that can eventually lead to patient harm if we do it the wrong way. It's just an example of benchmarking. This is a study from the Mayo Clinic from Mora. Matthew Mora, he collected a lot of data from follicular lymphoma and the outcomes over time. And this really puts a nice benchmark to development in follicular lymphoma in first-line treatment. You also see that since survival is almost near to 100% for a long time, this really puts a high bar for new treatment interventions. But then you can use real-world data to identify the unmet needs. For example, despite that the vast majority of patients with follicular lymphoma actually do very well, then these data from 2015 really identified that patients with early progression are the ones that have really poor, even poor overall survival. So this is a high unmet need in follicular lymphoma, and probably somewhere or an area that is already in focus. But can we then replace the randomized control trials? I think this is a question being debated, and I think this was considering why do we have randomized trials? When we have a randomized trials, we know that both patient groups typically get a treatment, and maybe this treatment is blinded. Hopefully it is, or often it is, if it's feasible. We also know that each patient is assessed the same way. They have the same number of clinical assessments at the same time points, and then we get the results out of it. We also have the randomization to reduce the risk of imbalance between the treatment arms. But I think the real main thing that makes randomized trials unique, or at least a part that is less often considered, is that you have these very strict inclusion and exclusion criteria. And this means that you have a pool of patients that have all entered the trial. They all look the same, and they could all have received both treatments. And this is not the case in real world data, because if you look retrospectively or look at a cohort of patients and you say that one patient got treatment A and one patient got treatment B, then it's probably not true that all patients could have received the same treatment. There would have been several reasons for selections. And this is also another way to illustrate this. This is when you look at a randomized trials, you may have patients, the red phases, that have a shorter survival than the green phases, but they look the same. You would not be able to tell it by allocating patients. So you have the randomization that ensures that these are equally balanced. If you have a single arm trial and you have an external control, you are at risk of having patients that may on the overall structure look like each other, but in reality they have some substantial differences. And if there is a minor treatment effect, as we often see in oncology and hematology, then this of course is really critical, because this can make two wrong conclusions about effect. But if there's a major treatment effect, then likely this thought about external control is more appealing. This is a study from Denmark in AML, just showing how trial participation predicts overall survival in AML. This is quite interesting because in Denmark we have a very high participation rate in AML trials. We have around 60% of the patients, regardless of age more or less, that were included in clinical trials. When you look at the overall survival, then you'll also see that the vast majority of patients in these was treated within a trial. The vast majority of patients that had, for example, intensive treatment were treated in a trial. But when you look at the survival, it's clearly different. So patients that were treated in the trial, despite many of them being treated in the control arm or even in negative trials, they actually just do better. And this is also the case when you do adjustments for imbalances of the typical inclusion criteria, such as performance status. We've also done something similar in lymphoma, and we presented this at ASH this year, and we looked at what does inclusion in a clinical trial, or what does meeting the inclusion criteria in a clinical trial mean to outcomes in patients with lymphoma. So we looked at the patients that were registered in the Danish lymphoma database, treated with R-CHOP, and had an age above 18 years with no CNS involvement, typical inclusion criteria in a trial. And of course, they needed to have information on survival outcomes. This is most of them because of the structure of the database. And then we looked at the high-level criteria for each trial. For example, we looked at that they fitted into the stage of the disease and the age category, for example, 18 to 80 years, and stage 2 to 4, for example. And then after this, we looked at the eligibility criteria, especially the organ eligibility. This was inspired by a study out of the Mayo Clinic. And then we had like between 1,500 and 2,100 that had these data available. When you look at the outcome of these patients, these were all treated with R-CHOP, then it's clearly different. So if you meet the eligibility criteria, we have the sufficient organ function, you clearly do better. This is the blue curve compared to if you don't meet the eligibility criteria, for example, have elevated liver enzymes or have poor bone marrow functions, then you clearly also do much worse. And what I think is interesting here is that when you look at the outcomes from the clinical trial, this is the stipulated line that we redraw from the papers of the clinical trial. Then when you select it seems to be changing a little on its own. When you select real world data or real world patients, the blue curve here, then and make them fit the eligibility criteria for a trial, then there's not that much difference, but there still is a significant difference between outcomes of trial patients and real world data, real world patients, but still you can make it much less by applying these eligibility criteria. So a caveat to using external controls in clinical trials, I think one of the issues of why there is a difference is that we are not really treating the sickest patients in clinical trials. And I think this study also by Dr. Morrow from the Mayo Clinic really shows this. This is in diffuse large B-cell lymphoma. It showed that patients that are treated immediately in the real world setting, like between 0 to 6 days after diagnosis, they of course, or not of course, but they do much worse than patients that have that can go a long time without treatment. For example, patients that are treated more than 35 days after diagnosis. And this, of course, matters for clinical trials, because when you need to be enrolled in a clinical trial, there's an enrollment period where you need to go through a lot of examination, and the most sick patients cannot go through all the examinations. Maybe they cannot go through an MRI scan, maybe you don't have time for PET scan, and so on and so on. And this, of course, means that you are preferentially selecting better patients for clinical trials. And I think especially in hematology, when patients often have an urgent need of treatment. I also think one of the issues that we have to be aware of when we try to match clinical trial data with real world data is that, and do these adjustments, is that the categorical variables we use are not truly binary, even though we are listing them like this. For example, having fulfilled the definition of refractory disease doesn't mean that all patients have the same outcome. You can have different degrees of refractoriness, even though you kind of formally fulfill that you were sick again within 6 months. You can have a refractory disease where you have a relapse progression with a stage 4 and CNS involvement. You can have a refractory disease where there is a single lymph node that is active, for example. And this, of course, have very different impact of outcome. And likely the patients with the less refractory diseases, even though they fulfill formal criteria, are included in trials. And similar, you can say with performance stages like the ECOG performance stages, even within the same category, for example, ECOG 2, there would be a difference in outcomes, and you can be ECOG 2 because you are sick from your lymphoma, and you can be ECOG 2 because you have a lot of comorbidity, and probably this matters a lot which one you belong to. This is a study in JCO from 2009, and I think that points to some of these problems. This was a study where they actually looked at oncology interventions. They looked at observational data where they studied treatment effectiveness in oncology and found the randomized controlled trials that kind of explored the same treatment intervention. So try to match and see if you got the same results when you look at the observational data versus trial data. And when you look at this, all these dots, the actual line of best fit is here. This is the red one. But if there was a perfect agreement between observational data and clinical trial data, then it should have been the blue one. So there's quite a substantial difference. And also when you see the figure B here, the gray area reflects the 95% confidence interval of the hazard ratio of the clinical trial. So you see here that actually a lot of the observational data hazard ratios are way beyond the 95% confidence interval of the clinical trial, and some of them are also even in the opposite direction. So there isn't that great an agreement, and generally there's only 40% agreement, like meaning that the treatment has the same effect, like either positive, no effect, or negative between observational data and clinical trial data. And this is true even if you kind of selected a subset of these comparisons that were considered to be particularly well matched. So I have an example of this also from our own data, like how do you interpret when there is a discrepancy? And you all know the PRIMA study where maintenance rituximab was tested in follicular lymphoma after first-line therapy, and that this really was associated with a better PFS, but no overall survival benefit. And probably this is also why it's less commonly used, I would say, in many countries now, because there is no final overall survival benefit, and this is true even after many years of follow-up. A study out of Denmark showed a quite different effect. This is follicular lymphoma patients, and patients with the blue curve were treated with maintenance, and the red curve was treated without maintenance. And you see that in terms of overall survival, then when you look at all patients, there is a clear difference. The overall survival is better with maintenance therapy. This is also the case when you restrict it to the CHOP-like group. And it's actually a quite significant overall survival benefit when you look at the PFS difference, which is kind of in the same magnitude. So it's quite unusual that a PFS difference of this size translates into such a significant overall survival difference. And this, of course, also persisted after adjustment for what you can adjust for when you use the clinical database. We have the lymphoma database, but you can question if could there be some residual confounding here. This is actually a similar study we did in Denmark a little differently. We didn't use the database. We used we used medical records to see how outcomes of patients treated with maintenance and without maintenance were, but only looked at patients with documented CR, PR, and only from a restricted time period of 2007 to 2014. And when you look here, the PFS difference is, we had a lot less patients, but the PFS difference is not significant, but maybe you can say that the PFS is at least a trend to being better with maintenance. But when you look at the overall survival, this is actually just significant. So you have a better overall survival when you get maintenance treatment. But when we looked at the reasons for death in the patients that didn't receive maintenance, rituximab maintenance, these were very non-lymphoma related. There were 5 of 7 deaths that occurred within the first 2 years. They were actually unrelated. This was lung cancer, chronic obstructive lung, pulmonary disease, and other reasons. So how can this be, and what to believe then? And I think one thing that is interesting here that we can use when we get some unexpected outcomes in observational data is this negative control outcome. And this is a method in epidemiology to assess for uncontrolled confounding or bias. And as you all know, you kind of have something similar in laboratory experiments where you have a negative control. And this is, of course, a control where you don't add an active drug. And in epidemiology or observational data, of course, you cannot control the exposure anymore because this has happened. So we cannot select who gets treatment A or who gets treatment B, but we can look at the outcomes and control the outcomes, or at least look at outcomes that we wouldn't expect to occur if we had managed to adjust fully for all confounders. And this is quite a complex figure. I also sometimes have difficulties explaining it myself, but this is kind of how this works. If you kind of have an intervention, for example, rituximab maintenance, and have an outcome, say overall survival, then of course you have some known biases like that can affect outcome, but maybe also affect whether you prescribe rituximab maintenance, or do affect if you prescribe rituximab maintenance. But this, since you know these biases, for example, age performance score, then you can adjust for it and try to eliminate this effect. But it could also be that, for example, these biases like poor performance score is also correlated with something else, like an unhealthy lifestyle and poor compliance, things like this, that you cannot fully adjust for, or maybe you're not adjusting fully for this association by just adjusting for the age performance. And maybe these healthy lifestyles or other health complications are correlated to some other outcome that is not at all related to rituximab maintenance. So this we also tested. This is unpublished data, but we tested it also in the Danish data again. And it's clear that if you had maintenance, then there is a significantly better outcome. And we only looked at patients alive 2 months after end of therapy to ensure that there isn't survival bias in this. It's interesting though that if you look at the outcome over time, like before we even had maintenance, and now in the later period when we had maintenance, but before we maybe stopped really using it again, then the outcomes are completely identical. And when you look at for example, the outcomes of some other endpoint, like how does giving maintenance affect developing other common cancers or dementia, then you also see that receiving maintenance seems to protect against these events. And this is of course because there is a selection of patients that we cannot fully adjust for. And maybe if you have a patient that during the treatment with follicular lymphoma are diagnosed with a colon cancer, then you don't put them on maintenance because they have a completely other health issue that should be managed before. Or if you have patients that hardly were able to turn up to get their induction therapy or had really poor compliance, then maybe this is the type of patient you put for observation. And maybe this is the type of patient also at risk of dying from a lot of other causes. So I'll just spend 15 minutes or 20 minutes talking about different aspects of real-world data, like how we can use it directly in clinical practice to improve clinical practice. And I think there's so many ways we can use to use real-world data today to improve clinical practice, because there's so many situations that are not really directly related to treatment and that are not explored in randomized trials or not even in trials. This is, for example, how we classify disease, how we do our diagnostic workup before the lymphoma diagnosis, how we do disease surveillance, or what to look for in patients that have completed treatment, like how to improve survivorship, how to look for late toxicity and which ones. It's also maybe looking at, especially if we have rare diseases or treatment interventions where randomized trials are not very feasible, for example, very rare lymphomas or rare events, or sometimes you also have the problem of simply that there is a low interest in conducting a trial because there's no economic incentive from industry in doing this, and the money in academia is typically not sufficient to do large randomized trials, at least not in our part of the world. I have one example of this from the Nordics, where we looked at disease surveillance in diffuse large B-cell lymphoma, and as you all know, like maybe more than 70% or around 70% of the patients achieve a CR and enter post-treatment follow-up. And of these patients that are in complete remission, really relapses are not that common, less than 20%. So this means that all the things we do for disease surveillance in these patients only benefit a very small minority of patients, a maximum of 20%. The rest will never be sick again. And we do a lot of things to detect relapse. We, at least at one point, and in some countries, you do preclinical imaging to detect the preclinical relapse, or you do a regular blood test, you do regular clinical examinations. And this has been the topic of several studies by use of real-world data, and I'll show you 2 examples of this. Both of them were something we did in Denmark and in the Nordics. The first study, we looked at the impact of imaging versus non-imaging relapse. Like, does it matter how you got your relapse detected? Do you have better survival if it was detected by imaging versus clinically? And you see here, this is looking at the multivariate analysis, looking at imaging detected relapse. It seems that there is a better outcome for patients who had imaging detected relapse. This has a hazard ratio way below 1. And when you look at only the diffuse large B-cell lymphomas, because this also included other types of patients, then it's still a significant improvement in outcome for patients who had imaging detected relapse. However, when we took out the indolent relapses, for example, then this significance disappeared, but still a clear trend toward better outcome. But there is some problems in doing it like this, and as we also pointed to in the paper we did, because you of course will have the lead time bias, and the lead time bias I've illustrated here. If you kind of have a disease that starts at one point and then exists for several months without giving any symptoms, and at one point when the blue arrow, it becomes symptomatic, and patients maybe have a few months, and then some patients will die from the relapse. Then if you do imaging regularly, then you can detect the relapse when you are out here in the preclinical, when the patient has a preclinical disease. And this means that if you then measure survival, then it would look like this line, like you will measure as the patient survived 10 months after diagnosis of relapse. But if you don't do any imaging, then of course you cannot discover the relapse before the patients actually have symptoms. And then when you measure survival after the relapse, then survival will look much shorter. And this is of course not true. This is simply just a matter of when you diagnose the disease. And this is the lead time. And this is something that comes into play when we do like these types of analysis. Because if you have imaging detected relapse, then you are likely to also have a significant lead time. There's another bias that maybe is less often considered, but I think equally important, is that you also have different diseases at relapse. You have very aggressive diseases where patients survive very short. You have very indolent diseases where patients survive for a long time and maybe respond well to treatment. And if you imagine that you have 13 patients or 13 relapses, maybe very aggressive relapses with a very, very short time from start of relapse until symptoms, well, then you have less chance of detecting these patients by doing random scans. For example, if you do a random scan here, you may be able to detect 5 patients in an asymptomatic period if you have a very short time between disease onset and development of overt symptoms. Whereas if you have very, very slow relapses that have a long asymptomatic period, then doing random imaging or doing imaging or assessments, you have a much higher likelihood of detecting patients with relapse at this point. And this means that patients in the imaging group that have a relapse are more likely to be the slow relapses versus patients that have the aggressive relapses. They are more likely to be in the clinical relapse or clinical symptoms leading to relapse, because they, of course, develop very fast these symptoms and report themselves often. So we did something else to see if we could come a little nearer to a conclusion on this. And then in this setting, we used the fact that, for example, in Denmark and Sweden, we have different practices regarding use of imaging during follow-up of diffuse large B-cell lymphoma. Sometimes you can also do this if you have 2 hospitals that have different practice. But in the Nordics, we actually had 2 countries which had completely different guidelines. In Denmark, we had a recommendation for imaging every 6 months for 2 years at a minimum, whereas in Sweden, the guidelines discourage imaging if you were in CR after first-line treatment in DLBCL. And then we use this to compare outcome of patients in Denmark and Sweden that were in CR. And the strengths of this type of analysis is that we are very similar countries. We have similar healthcare systems, fully tax funded, and also quite centralized treatments, although Denmark is more centralized than Sweden. Then everything occurs in hospital and not in private oncology practices, for example, as it does in some countries. And then treatment of diffuse large B-cell lymphoma is also very standardized, especially when you look at the younger patient group below 65 years, that would be candidates for high-dose therapy if they relapse at first relapse. When we looked at this, then there was clearly no difference in outcomes. So patients in CR in Denmark and Sweden had completely identical outcomes, despite the fact that we use a lot more imaging. And this is, of course, a type of indirect evidence that imaging doesn't work, but it's not really a final conclusion, because of course there are some issues in analysis like this you have to take into account. For example, we know that imaging protocols in Denmark were largely adhered to. We did a questionnaire and all physicians responded that they adhered to this and did imaging, but we didn't have data on how this was actually done and if they actually did adhere to it in reality. And then the same in Sweden, for example, they also confirmed by asking experts that they adhered to not doing imaging, but of course, we don't know if these patients actually did have imaging anyway, or they did imaging, were more likely to do X-ray imaging in Sweden because they didn't have the routine imaging. So this is kind of like an intention to treat analysis, and would be interesting to look at the per protocol and see how much imaging was actually done. The final example I will give before going to the Q&A is you can also use real data to evaluate treatment effectiveness. And this is really important to discuss this effectiveness, especially the efficacy from clinical trial versus the effectiveness you see when you implement the treatment. Because I think clinical trial settings and the way clinical trial patients are treated are just completely different from what patients in the real world setting, how they are treated. Trials are well funded. They are clearly, at least in my part of the world, often more well staffed. They have research nurses that take very good care of the patients when they are in a trial, and we have not so many nurses, at least not the same time, for patients that are outside trials. Often also patients that are in trials are seen by more experienced physicians. They are maybe seen at larger academic centers, the largest ones. And patients are also much more engaged. Patients that enter clinical trials are likely more engaged in their health, have higher health literacy than patients that are treated outside, where there's really a lot more diversity, and at least in many European countries, maybe also in US now, a significant lack of nurses and less optimal observation of patient, I would say. And it's really important to look at the real world effectiveness from the patient perspective, because patients need to know what the likely treatment outcomes are, and in order to make informed treatment decisions, and also to know the best possible treatments. And especially when we come to the special populations and safety, then knowing how these new treatments, how the effect of new treatments are in patients with poor renal functions or patients with high levels of comorbidity is really valuable. But I also think this is important from a broader healthcare perspective, because you really need to understand what kind of value new treatments add to healthcare, and if you are able to get the same positive effects from new treatments as you did expect from the clinical trial results. And this is, of course, an old story. This is the CHOP versus R-CHOP. Treatment is more than 20 years old now, or around 20 years old, showing that there was a substantial survival difference when you add rituximab to CHOP. And this is, of course, now standard treatment for diffuse large B-cell lymphoma. We looked at this in our own data in the Danish lymphoma database, and this is a database that really covers all patients in Denmark that are treated for lymphoma at Danish hematology departments, meaning virtually all patients has a coverage of way beyond 95%. And this treatment was, of course, introduced to all patients, regardless of age, performance status. If you could tolerate CHOP, then you also receive rituximab. And it's interesting to see here that really that in a setting like this, where we had quite a lot of patients with poor performance status, where we have all the patients with comorbidities, where we have all patients with, for example, poor liver function, maybe poor kidney functions, then you see that the relative survival, this is not overall survival, this is the relative survival of diffuse large B-cell lymphoma for men and women, has clearly become much better. This is the rituximab versus the no rituximab. It's clearly become much better after we had rituximab for these patients. So this really confirms that there is a significant benefit of adding rituximab also in the real world setting. But I think now this was, of course, also a significant overall survival benefit that we saw in the clinical trial in that with rituximab versus no rituximab. But when you have new treatments in diffuse large B-cell lymphoma, this is the first one for many years, actually, since rituximab in the first line setting, where we have polatuzumab presented at ASH this year, showing that there was a disease-free survival benefit of adding polatuzumab to R-CHOP, but without vincristine, of course, versus the standard R-CHOP. There was a disease-free survival benefit, but no overall survival benefit. And in these situations, of course, the treatment effect is much more marginal, and then it becomes much more important when this is introduced, if it is introduced in Denmark, but also in other countries, to really assess if you can reproduce these efficacy effect in the real world setting, because you change the patient population. You don't do the same type of monitoring, maybe with regular CT scans, and maybe you don't capture if they have indolent relapses, for example, that maybe don't matter too much. Maybe they go into observation sometimes anyway. And things like this can really make a change. And when the trial results are in the marginal end, then this can really have an impact, I think, and it's important. The final example I will give is the use of CNS prophylaxis, something we have been working quite a lot on, and something that has not really been tested in clinical trials. As you all know, CNS relapses are really a quite infrequent event, but still 5% of diffuse large B-cell lymphoma will have a CNS relapse, higher in high-risk groups. And the median overall survival is really poor, so typically less than 6 months, and it's really a few patients who achieve a long-term remission, again, less than 25%. We have a lot of risk factors for CNS relapse. We have the external sites, the testis, adrenal, kidney involvement, and we have the CNS IPI, which is now the most commonly used index. And typically patients with high risk CNS IPI score have a 10% risk of CNS relapse, and these are considered for CNS prophylaxis, which is really rational, because if you have an outcome that is, or a complication that is really with a very poor outcome, then it makes sense to try to prevent it. So in Denmark, for a long time, we used this for high-risk patients. We use higher dose methotrexate predominantly. And we had also previous data from single-arm trials or from observational data showing that patients that were treated with high-dose methotrexate actually had a quite low CNS relapse rate. But these were small series, but still in the area around 3%, which was much less than maybe the 10% expected from being a high-risk patient. So we spent some time looking at this. This was presented by Dr. Catherine Lewis at ASH 2021. And we collected data from several European, US sites, Australian sites, and looked at exclusively high-risk patients, like patients that were said to be high-risk CNS relapse. How did they do if they had high-dose methotrexate versus no high-dose methotrexate? And you see here the risk of CNS progression, and the scale here is 20%, so the difference looks maybe bigger than it actually is. The risk of CNS progression is actually not that different. If you have high-dose methotrexate, the yellow line here, you are out at 5 years, you have a risk difference of 1.1%. And this means that you need to treat 100 patients at least, if the point estimate is the right one, at least 100 patients, or around 100 patients, to avoid one CNS relapse. And this is a very tough treatment with a lot of days in hospital and a lot of resources used, and also potential toxicity and delays in R-CHOP treatment and so on. But there is a problem during these analyses as well. As I'm sure you're familiar with, there is this immortal time bias, because you can imagine you have different situations or different interventions you explore. If you start the time here at time 0, and your eligibility criteria, for example, assessing that you are high-risk patients, and the high-dose methotrexate, the treatment you want to test, are both before the time 0, then there's no immortal time bias, right? So these situations, like the two first, there's no immortal time bias. But for example, when we look at CNS prophylaxis, use of CNS prophylaxis, then we may assess the eligibility at the time 0, for example, assessing that they are actually a CNS high-risk patient. But the treatment intervention is after time 0, so you measure the occurrence of CNS relapse after diagnosis of diffuse large B-cell lymphoma. But of course, if you are receiving CNS prophylaxis, for example, high-dose methotrexate, in the end of R-CHOP treatment, this also means that for the first 4 or 5 months, you didn't have a CNS relapse. So there is an immortal time bias and an important bias here. So this is why we also looked at it in a different way. And this is maybe a way to solve this, to change the start of the follow-up, to say that, okay, we only look at the patients that are in complete remission now. And when you do this, then the risk difference is a little bigger, actually. But it's still insignificant. So there's no significant advantage of receiving high-dose methotrexate as CNS prophylaxis, even if you look at only the patients in CR. And actually, this difference should have been more eliminated if there was a survival bias. So I think we can also trust the results we had where we started the time at the diagnosis. I think for the sake of time, I think I will actually stop here so we can have a Q&A. This was just a brief review of real-world data, how to use it, and what some of the biases are. Should I stop sharing the slides, or?
Yes.
Yeah.
Great. Thank you, Dr. El-Galaly. I think that was a wonderful tour of potential uses and pitfalls of real-world data. As we're waiting for questions, I have one question. So you alluded to CAR T-cell therapy and the use of real-world data and control arms. We're seeing that very commonly. For example, with lymphoma, we had a phase 1/2 trial that led to CAR T approval, ZUMA-1. And then we had a real-world control arm, and then you could see that there's a significant difference. The authors of the real-world control arm, they use the same inclusion-exclusion criteria as the CAR T trial, but what are some of the pitfalls or benefits of using such an analysis?
Well, I think that the benefit is, of course, that you can run a trial that has few patients, and you can offer experimental treatment to all patients, knowing that the standard treatment is actually not that good. So all patients have a chance to receive CAR T. So I think this is the advantage, like a faster development. But I think the pitfall is, of course, that as I showed, even though you use the same inclusion-exclusion criteria, then saying that you have a patient that they all have performance 0 to 2, for example, then even within the spectrum of having performance 2, there's a huge difference, and there may be a reason why some are performance 2, or maybe the underlying reason why being performance 2 could be comorbidity, which may be a worse associated with a worse outcome than if they are performance 2 because they are sick of the lymphoma and these symptoms disappear as soon as you start treating them. And this is also similar. A similar thing is also like the time between relapse and need of treatment. So if you really need urgent treatment, I don't know, I don't recall if they adjusted for this, but if you really need urgent treatment like tumor lysis and all these things, the very aggressive relapses, then probably you're not going to be in a CAR T trial because you cannot wait for treatment. So I think there are some pitfalls. I think one of the options to use these types of analysis is, of course, if the expected benefit is very big. So if you kind of have a very poor treatment and you see that you have a significant or quite good outcome with the experimental treatment, then it's like easier to conclude that it's true than compared to if you have a very minor difference, because then these small things or small lack of adjustments can actually make a huge difference. But I think now, after having real world data also in CAR T outcomes, you also see that patients treated in the real world setting actually have similar outcomes to the trial data. So I think for that analysis, it was probably quite true, I think. But I think one needs to be careful when concluding on these analyses, for sure.
Thank you. I see there's a Q&A. So we have a question from the audience. Is there a good example of FDA-approved targeted therapy that subsequent real-world data shows no overall survival benefit? We often hear the refrain that FDA is approving cancer drugs that don't really work. And this question is from Nathaniel Gray.
Actually, when I'm asked like that, I don't have any example just at hand, but I would expect that this could be a quite frequent, that this could occur quite frequently if you have, as I showed, for example, the recent lymphoma trial on polatuzumab, if you have very minor differences in the outcome between experimental arms, the experimental arm and the standard arm, I think just minor changes in the patient population can matter a lot. So I would believe that there is a possibility to see this. I think there is a difference also when you look at if the question pertains to single arm trials, and then you go out afterwards and look at real world data and look at whether patients treated with the targeted therapy did better than patients treated before availability of the targeted therapy. Again, I think this is also something you have to be cautious about, because giving targeted therapy and often requires some diagnostic workup, at least some time to wait for tumor profiling, and then again you end up taking out the sickest patients that are in urgent need of treatment. So I think it's definitely an evolving area. I think there's a lot of things to be solved, and I also think the paper from JCO I showed from 2019 really shows that you have to be careful, because you have so often seen that trial data shows a benefit of a treatment in one direction, and then later observational data shows this in another direction, or no benefit, or vice versa. And that's not because one of the things are necessarily true. It could be that the trial is focusing on a very narrow population, and it really is true that the observational data cannot reproduce it because you have all the comorbidities. But it can, of course, also be that the problem is in the patient selection, that patients don't really look like one another when you have observational data, that there are some end biases that you may think you are adjusting for, but you can only adjust for the differences you really know that is there, and there's so many other things that you don't know of that can explain this.
Great, thank you. I think we have another question, and I see that was answered. So I guess a follow-up question to that is, how should regulatory agencies like the FDA and EMA use real-world data, especially now that we have a lot of drug approvals based on phase 2 trials, single-arm trials?
Yeah, that's a good question. I'm not sure I have the answer to that. I think one thing that is interesting is if you, after you have your approval and start using the drug, also prospectively collect outcomes data, and maybe especially design observational cohorts where you have all the data available so that you can really match the trial, or at least have the data point, and then you can see, for example, if the observational data, if you subset on a group of patients that look like the trial, at least you have the same benefit. Because of course, if a drug is approved and it's implemented in clinical practice, then it is approved based on a study, and it's approved for use in a patient population that was defined by the trial criteria. But there's no guarantee that it works when you expand outside these criteria. So I think the first thing is that really to ensure that you can reproduce the effect in the trial-like population. Then subsequently also, we need to have data that can document that when we take it out to elderly patients or take it out to more sick patients, that this is really also benefiting them. So there's two aspects of it, I think.
Great. We have a follow-up question from Dr. Gray. Do FDA-approved targeted therapies in the US immediately become available in Denmark? Is there a system that can exclude marginally effective drugs?
Yeah, first of all, I think you have a lot more drugs approved in the US based on single-arm trials than is approved by EMA. And then when drugs are approved in Europe, then they are technically available, but in reality they are not, at least not in Denmark, because we also have like a regulatory body that determines whether the cost effectiveness of a new drug and whether the cost effectiveness compared to what we do today is sufficient. And I would say that actually quite a lot of drugs have not been implemented in Denmark. For example, we don't have access to CAR-T therapy, despite we have a quite well-funded, I would say, overall well-funded healthcare system, and it's also among the richer countries in the world. And then this is something that was assessed as being not sufficiently effective, and especially due to the lack of randomized trials, so you could not really be sure that the effect was there. And there are several other examples also that drugs are not taken into first line, even though trials maybe have shown that there is equal effect but less toxicity because of the pricing. And this is also because we have a tax-funded healthcare system. This means that we have a certain amount of money, and this is it. And there are so many new drugs now, and they are quite expensive. And then I think this is a realizing that we cannot afford everything. And I think the structure of US healthcare is probably a little different when you have the insurance-based healthcare that doesn't have these limitations in the same way.
Great. So I think our last question today is from Daniel Kapp, who says, an excellent review. In the US, socioeconomic determinants of health are important in outcomes. Is this less of a problem in a country like Denmark with universal healthcare coverage, or is access to care still a problem?
I think even though we have universal access to healthcare and in theory treatment should be equal, then I think that there is still inequality in healthcare, and we also know that from data on transplant, for example, allogenic transplantation, that there is not the same access or same likelihood of receiving treatments. I think we have very centralized hematology, and we have the same offer to all patients, but there is also quite a lot of steps where things can still be unequal, because if you have a cancer, then at first point you need to go to a general practitioner, and there can be barriers for even going to a general practitioner to have your diagnosis. So it may come later if you are poorer health socioeconomic status, and also maybe in the step before we see them, maybe it is less likely that these patients are referred to additional diagnostic workup. Maybe they are less able to say exactly how they feel and demand that there's something serious wrong. Maybe they are more delayed in diagnosis. And also when we receive them, there can also be inequality because despite having the same offers to everyone, then for example, having febrile neutropenia or infections, maybe some patients are better in responding to these symptoms, maybe we don't have a system that really takes care of the patients that cannot really manage to respond themselves. I think this is a huge unmet need because we assume that everyone can respond the same way to symptoms, and this is not the case. So I think even though we have in theory the same offer to everyone, then in practice there are differences.
Great. Thank you, Dr. El-Galaly. This was a wonderful talk. And thank you everyone for joining us.
Thanks for giving me the opportunity.